Good morning.
Typically, you will perform a comprehensive physical examination on new patients or patients being admitted to the hospital. This provides fundamental knowledge about the patient and helps identify or rule out physical causes related to your patient's health concerns. A skilled head-to-toe examination of adult patients requires a thorough knowledge of the techniques of examination for each region of the body. You should be prepared to detect normal variations and abnormal findings. The patient's health and well-being should be the primary focus of the examination, but you must promote the patient's personal comfort as well. Take time to adjust the examining room's environment prior to the examination, making changes in lighting, sound, or privacy, for example. By demonstrating respect for the patient, you promote the patient's comfort and relaxation, which helps ensure a successful examination. Another key to patient comfort is your attention to proper draping during the examination, combined with communication about your intentions as you move from one regional examination to the next. Your patients will appreciate knowing why you are adjusting their gown or causing them even minor discomfort. Minimize the number of times you ask the patient to change positions, from sitting to supine or from supine to standing, for example, to assure patient comfort. Developing a systematic sequence of examination greatly aids your ability to conduct an accurate physical examination with thoroughness and efficiency. With experience, you will acquire a routine that works well for you and for the patient. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. For a healthy patient, a complete head-to-toe assessment should take beginning students about 20 to 30 minutes. With the patient sitting, begin your assessment with a general survey, inspecting the patient closely, literally from head to toe, in order to form impressions for your later written assessment. Note characteristics such as apparent state of health, ease of breathing, height, build, and sexual development. Obtain the patient's weight. Note posture, motor activity, and gait, as well as dress, grooming, personal hygiene, and any odors of the body or breath.
Okay, very good. So,
Observe the patient's facial expressions and listen to the patient's manner of speaking as you note his or her state of awareness. Now measure vital signs. When measuring blood pressure, select a cuff of the appropriate size and position the patient's arm properly at heart level. This will help ensure an accurate reading. Record the patient's heart rate by checking the radial or, in older adults, the apical pulse. Next, check respiration. Listen to the number of respirations per minute by subtly placing the stethoscope over the patient's trachea. Next, check the patient's temperature. 3 methods are commonly used: oral, via the tympanic membrane, or at times rectal. Oral temperatures are the most common, but should not be used for patients who are unconscious, restless, or unable to close their mouths. Begin inspection of the patient's skin by observing the patient's face. Assess the facial expression, skin moisture or dryness, any facial swelling or asymmetry, and check for any cyanosis in the lips. Inspect and palpate the patient's fingernails, looking especially for any clubbing or cyanosis. Continue your assessment of the skin as you examine the other body regions. Note color, pigmentation, texture, hair distribution and thickness, and any lesions. Look for nevi, scars, or other distinguishing characteristics, noting their placement and dimensions. When you see nevi or moles, assess for melanomas using the ABCDE method. Inspect for asymmetry, irregular borders, color variation or change, especially blue or black, diameter larger than 6 millimeters, and elevation. If any of these 5 aspects is present, consider referring the patient to a dermatologist for further evaluation. In sun-exposed areas, flaking ulcerated lesions are suspicious for a squamous cell carcinoma and shiny raised lesions for a basal cell carcinoma. Next, assess the head, eyes, ears, nose, and throat. Palpate the scalp, looking for any depressions of the skull, which might indicate head trauma or previous surgery. Inspect the hair and its texture, looking for nevi, lesions, or even lice. Inspect the face. Note whether the facial expressions and eyebrows are symmetric.
So I'm going to turn the lights out and we're going to check your pupils, okay?
Check the color of the conjunctiva and sclera, looking for pallor in the conjunctiva or icterus in the sclera. Inspect each cornea, iris, and lens, noting any injection of the cornea, especially around the iris. Compare the pupils and test their reactions to light and accommodation. With an ophthalmoscope, inspect the ocular fundi, checking carefully for sharpness of the disc margins and especially any blurring of the margins, suggesting papilledema, shown here. Next, examine the ear canal and drum using your largest ear speculum and holding the otoscope at an upward angle. Check auditory acuity. If acuity is diminished, check lateralization using the Weber test, and compare air and bone conduction with the René test. Next, inspect the anterior and inferior surfaces of the nose. Note any asymmetry or deformity. Then, inspect the inside of the nasal passages with an otoscope. Palpate for sinus tenderness by pressing up on the frontal sinuses from under the bony brows, then press up on the maxillary sinuses.
Okay, I'm going to check your mouth, your lips.
Inspect the mouth, observing the symmetry, color, and moisture of the lips, and note any masses, ulcers, cracking, or scaliness. Inspect the oral mucosa and note the color of the gums, normally pink. Inspect the gum margins and the interdental papillae for swelling or ulceration. Inspect the patient's teeth and look for abnormalities. Inspect the hard and soft palates, the uvula, tongue, and other structures of the mouth. Pay particular attention to the floor of the mouth and the sides and undersurface of the tongue, for here is where leukoplakia or cancers can develop. Next, you may wish to perform a brief assessment of the 12 cranial nerves while the patient is sitting and facing you. Cranial nerve 1, the olfactory nerve, is typically not tested unless a neurological problem is suspected. In the head-to-toe assessment, cranial nerve 2, the optic nerve, can be assessed with a test for visual acuity by using a Snellen eye chart. Pupillary response was tested earlier. Cranial nerves 3, 4, and 6 control extraocular movement.
All right, I'd like you to look straight ahead, just right over my shoulder, and then I want you to follow my finger, okay? Excellent.
Next, test for the several components of cranial nerve 5, which includes motor response, sensory response, and the corneal reflex.
All right, I'd like you to just clench your jaw for me. Just, okay, very good. And then I'm just going to check sharp and dull.
Okay.
So tell me if you're feeling anything brush your skin. Just say yes or no.
Yes.
Cranial nerve 7 is assessed by inspecting the patient's movements of facial expression.
Raise your eyebrows for me. Good. And relax. Squeeze your eyes tight shut. Good. And puff your cheeks. Relax. And show me your teeth. Excellent.
Next, assess cranial nerve 8, which is responsible for hearing. test one ear at a time.
I'm going to whisper in your ear and tell me what you hear.
21.
Excellent.
14.
Very good.
Assess cranial nerves 9 and 10 by listening to the patient's voice. Is it hoarse, or does it have a nasal quality?
Open your mouth.
Here, you'll also ask the patient to say ah, or to yawn as you watch for symmetric movement of the soft palate, uvula, and the interior and posterior pillars and pharynx. For cranial nerve number 10, warn the patient that you are going to test the gag reflex. Then, stimulate the back of the throat lightly on each side in turn. Assess cranial nerve 11 from behind the patient. Look for atrophy or fasciculations in the trapezius muscles. Ask the patient to shrug both shoulders upward against your hands. Note the strength of the trapezius. From the front, ask the patient to turn his head to each side against your hand. Observe the contraction and force of the opposite sternomastoid and note the force of the movement against your hand. Assess the 12th cranial nerve by inspecting the patient's tongue for atrophy or fasciculations.
All right, I'd like you to stick out your tongue for me.
Then, with the patient's tongue protruded, look for asymmetry and deviation from the midline. Once you have completed any assessment of the 12 cranial nerves, inspect the neck by palpating the anterior and posterior cervical lymph nodes. For each node, note its size, mobility, and any tenderness. Note any masses or unusual pulsations in the neck. Next, palpate in the sternal notch to check the position of the trachea. It should be midline. Ask the patient to take a sip of water and inspect for the thyroid gland as the patient tips his head back, then swallows.
Just hold it in your mouth. Okay.
From in front of the patient, inspect and palpate the region below the cricoid cartilage for the thyroid isthmus and for any glandular enlargement.
You can lower your head. I'm just going to feel for the...
Repeat, standing behind the patient. Positioned behind the patient, continue by inspecting the muscles of the upper back. Observe shoulder height for symmetry. Then, palpate the spine and muscles of the upper back.
Check your spine. Any soreness there or tenderness?
No, it's fine.
Inspect, palpate, and percuss the chest and lungs. Percuss the lungs in a ladder pattern, going from side to side as you move down the thorax, from the apices to the basis of the lungs. Normal lungs are resonant. Locate any areas where you hear abnormal notes. Next, use percussion to identify the level of diaphragmatic dullness and measure descent of the diaphragm. To assess respiratory excursion, place your thumbs close to the patient's spine at the level of the 10th ribs and spread your hands lightly over the lower thorax. Ask the patient to inhale deeply and exhale fully while you watch the divergence of your thumbs and feel for the range and symmetry of movement of the thorax. Using the diaphragm of the stethoscope, observe the rate, rhythm, depth, and effort of breathing, and listen for adventitious sounds that may indicate abnormal respiratory conditions. Listen to at least one entire breathing cycle at each location, including over the right middle lobe under the axilla. Once you have already examined the patient's hands and upper back, you may decide, based on your observations, that a more extensive musculoskeletal examination is warranted. If so, while the patient remains sitting upright, inspect and palpate the temporomandibular joints, hands, wrists, elbows, shoulders, and neck. Inspect and palpate the joints, then check their range of motion. For the shoulders, assess external and internal rotation. With the patient still seated, you can perform a neurological examination of the patient's upper extremity. First, visually assess the patient's muscle bulk, then check muscle tone. Now test muscle strength. Ask the patient to squeeze your fingers as hard as he can. Next, test the patient's biceps. Then test the triceps and repeat on the other side.
Okay, with your eyes open, touch my finger.
Next, check for point-to-point movement.
And now again. Good.
And assess rapid alternating movements. Together, these exercises help you assess the patient's upper extremity strength and coordination.
Excellent.
Examination of the breasts is important for both female and male patients. While the techniques of examination for men and women patients are similar, the female breast is usually more dense, and its examination should therefore be more thorough. Palpate in a smooth rotary motion, assessing the breast tissue for consistency, tenderness, and nodules or masses. In the woman, to begin the examination, visually inspect the breasts with the patient seated and her arms at her sides. Inspect the breasts with her arms raised and with her hands placed on her hips. In either sex, inspect the axillae and feel for the axillary nodes. Feel for the epitrochlear nodes as well. Although examination of the male breasts may be brief, it should not be omitted. Inspect for symmetry and size, and palpate each nipple, areola, and breast for nodules. To examine the anterior thorax, have the patient remain supine and breathing normally. Observe the condition of the skin and inspect the chest for deformities, asymmetry, and respiratory movement. Next, palpate the chest wall to locate any areas of tenderness or to assess any lesions or abnormalities. Next, percuss the anterior thorax in symmetrical areas, proceeding from the supraclavicular area down to the sixth rib or below. Again, compare both sides. Identify your percussion notes and their locations. Using the diaphragm of your stethoscope, you should hear breath sounds over the anterior lung fields. With the patient supine and elevated to a 30-degree angle, begin the cardiac examination.
And relax.
Often, the first step in your cardiovascular assessment is estimating the jugular venous pressure, or JVP. Measure the JVP in relation to the sternal angle. Next, inspect and palpate the carotid pulsation. This will include both palpation and listening for bruits. Inspect and palpate the precordium. Note the location, diameter, amplitude, and duration of the apical impulse. Listen at each auscultatory area in 6 positions. Start with the diaphragm of the stethoscope at the right upper sternal border and the left upper sternum. Listen at the left lower sternal border and the apex with the bell. S1 is louder at the apex and S2 is louder at the base. Listen for physiologic splitting of S2 at the upper left sternal border. Also listen for any abnormal heart sounds or murmurs. Lower the table flat. Expose the supine patient's abdomen, draping the lower abdomen at the suprapubic level. First, listen for active bowel sounds.
Listen to your abdomen.
Palpate lightly, then deeply. Assess the liver and spleen by percussion and then palpation. Try to feel the kidneys and palpate the aorta and its pulsations. Examine the peripheral vascular system by palpating the femoral pulses, then the popliteal pulses. Palpate the inguinal lymph nodes. Inspect for lower extremity edema, discoloration, or ulcers. Palpate for pitting edema. Assess the pedal pulses. With the patient standing, inspect for any varicose veins. With the patient remaining supine, you may wish to complete the musculoskeletal examination. Examine the hips, legs, knees, ankles, and feet. Inspect and palpate these areas for tenderness, deformities, nodules, swelling, corns, or calluses. To complete the neurological examination, assess lower extremity strength, bulk, tone, sensation, reflexes, and Babinski's to complete your examination of the nervous system. Inspect the patient's musculoskeletal system, both supine and standing. With the patient standing, examine the alignment of the spine and its range of motion, as well as the alignment of the legs and feet. Observe the patient's gait and ability to walk heel to toe and walk on the toes, the heels, hop in place, and do shallow knee bends. Do a Romberg test and check for pronator drift. A complete examination of the nervous system can be done at this point, if not done earlier. It consists of 5 segments: mental status, cranial nerves, motor system, sensory system, reflexes. The mental status is determined by assessing the patient's orientation, mood, thought process, and content, abnormal perceptions, insight, and judgment. As previously outlined, the 12 cranial nerves may be examined here. The motor system consists of examination of muscle bulk, tone, and tests of strength of major muscle groups of the upper and lower extremities. Assessment of the sensory system evaluates pain and, if indicated, temperature, light touch, vibration, proprioception, and discrimination. Test the reflexes of biceps, triceps, brachioradialis, patellar, and Achilles deep tendon reflexes and the Babinski's. Genital and rectal examinations are often performed at the end of the head-to-toe examination. An examination of male patients begins with inspection of the genitalia, continues with inspection of the sacrococcygeal and perianal areas, and includes palpation of the anal canal, rectum, and prostate. Genital and rectal examinations of female patients begin with inspection of the external genitalia and continues with a speculum examination of the vagina and cervix, including a pap smear and cultures if indicated. The clinician may also perform a bimanual examination of the uterus and adnexa, followed by the rectovaginal and rectal examinations if indicated. Pay particular attention to draping during these examinations, and whenever possible, continue to minimize the patient's exposure. Remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
The patient is of medium height and weight, middle-aged, and responds well to questions. He is relaxed, his skin is warm and moist. He is well groomed, his color is...
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the patient head to toe. The more adept you are at the principles of clinical reasoning, patient interviewing, and therapeutic support, the more effective your physical examination will be to the well-being of your patient.